Good morning, everyone. Happy Sunday. Welcome to Dr. J's Prescription for Health. I am your host, Dr. Malia Jensen. I am a board certified family physician. I am located in Des Moines, Iowa. Where are you guys listening from? I have my co-host here. He is helping me from heaven. This is Tucker, and Tucker is co-hosting from heaven. So if you have questions, please put a QQQ in front of your question so I can see it more readily and get you answered if I know the answer. Okay, so today, happy Sunday. All right. I want to start out by asking you a question. I want to give you a scenario. Let's say that you are allergic to peanuts. And the only way now at this point that you can survive a peanut allergy is if you have EpiPens available. So you have a allergy to peanuts, it's pretty severe, and the antidote is an EpiPen. Do you simply continue to eat the peanuts or the peanut butter and have the EpiPens available? I'm guessing many of you will say, that's ludicrous. I don't want to risk that. I'm not going to eat peanuts any longer, but I'm still going to carry the EpiPen, but I'm going to avoid nuts or something similar like peanut butter. Right? You guys I'm guessing, would agree with me that you would simply remove the allergen because you don't want to take risks. Okay? Now, let me use that same analogy and talk about diabetes. Diabetes is a condition of carbohydrate toxicity. You get diabetes from high blood sugar. High blood sugar is obtained by eating carbohydrates. Eventually, you cannot use all of the carbohydrates you take in, and your body becomes resistant. So with the same scenario in place, we have medications for diabetes. Do you continue to consume the allergen, so to speak, the carbohydrates that are causing your disease, and just take the medications? Now, some of you will say, yeah, but doctor, one is life-threatening and the other's not. No, one is life-threatening right now. The other is life-threatening maybe down the road. And so you say, I'm just going to take my chances. But you see how the scenarios change depending on what we're actually talking about. But in reality, it's almost the same, right? Except for one is possibly an acute death in seconds, and the other could be 10 years from now. So the number one cause of cardiovascular disease, a heart attack, is diabetes. Do we just play the odds? We continue with our diabetes, so we'll continue the carbohydrate, the toxicity of diabetes, which is carbohydrates, knowing full well, because we've been told that coronary artery disease or cardiovascular disease results from, most commonly, diabetes. What is it that you want to do? Okay, so you want to go to the doctor, right? You want to know your risks. Do you have it? So you are in our head, a person relies on a diagnostic, relies on a blood test, relies on a urine test, relies on a calcium scoring test. But what are we doing with these diagnostics? Because all I'm doing with that is giving you a diagnosis. That's why they're called diagnostics. I'm giving you a diagnosis. If your blood sugars are high, if your insulin is high, if your hemoglobin A1C is high, if your triglycerides are high, you have underlying diabetes, if not full-blown diabetes. It amazes me that some doctors could say, no, you don't have diabetes until you reach 7.0. Well, let's just say it's 6.0. But if you're 5.9, you don't have diabetes. It's almost like there's this magical cutoff. You got diabetes, you don't got diabetes by 1/10 of a point. you have underlying diabetes 10 years in advance of that 5.9 going to 6.0. That's my definition of diabetes is 6.0. Another doctor might say it's 7.0. By that time, you have lost 50% or more of your functioning beta cells in your pancreas. Beta cells secrete insulin. That's what they do. So when your blood sugar goes up, the pancreas sees that and secretes insulin to help bring the blood sugars down. That is one mechanism of insulin. So if we are allowing the pancreas to be overstimulated all the time, do you not think that the pancreas is going to get worn out? The beta cells are going to get worn out. The body is becoming resistant to all of the blood sugar, hence diabetes. Diabetes is high insulinemia, high insulin in the blood due to high blood sugars. Are you going to make a change? What is the change? Is it dabbling in some carbohydrates here and there? Well, do you want to dabble in some nuts here and there, knowing that you have a deathly reaction to it? Well, someone would say, you know what? I'll take the deathly reaction 10 years from now. I mean, there are people who do that, who say that, and that's fine, but I want to provide as much information as I can so you can make a good decision. By the way, we are live on Instagram today, just Instagram. This is not medical advice. This is for information purposes only. So you are equipped with information that you can use to talk to your doctor or talk to your healthcare provider. This is information. I am a doctor, but you are not my patient. You are patients of someone, just not me. Okay? So I just want to make that perfectly clear. Now, if we're talking about diabetes and we're talking about, perhaps dabbling in some carbohydrates here and there, knowing that we have a disease of toxicity, which in all reality, it's not really a disease. It's actually a symptom of something else, is how we get diagnosed with what doctors will call a disease. I know that sounds confusing, but you don't have a disease of high blood pressure. That's a symptom of something going on in your body. Okay? You don't have a disease of diabetes, so to speak. That is a symptom of something going on in your body. High blood sugar equaling high insulin. It's destroying your body, whether you know it or not, whether you feel it or not. Likely you're feeling it and you just get used to it. You'll chalk it up as an aging process. You'll think, well, that's normal. But I'm here to tell you that it's not normal to have aches and pains. It's not normal to simply have high blood pressure over time. Those are not normal things. We have mechanisms in our body that try to help when stuff goes wrong. They're called defense mechanisms. And you having high blood pressure is a defense mechanism, something going on in your body. What is it? Is it high insulin? That's the most likely cause. Doctors call it idiopathic hypertension or essential hypertension, meaning we really don't know what the answer is, but here's your medicine. You don't want to do anything about it. You just want to take the medicine. Some of you will choose that. Hopefully you've had enough information presented to you by your doctor that will help you decide whether or not you just want to live with it and take the medication. Again, these are choices that you have to make, and I'm not going to tell you what to do. I just want to provide you with the information so you can make a good decision. That's what I do. That's what doctors should do. But it seems that doctors do not take the time to talk to you about your disease. And in effect, they've been paid a lot of money to be taught a one-sided storyline. Some doctors are jumping out of that matrix and they're starting to learn a two-sided storyline or a three-sided storyline. When you feel confused about your symptomatology in your body, and one doctor will tell you this and another doctor will tell you that, you get confused. Well, that should tell you that you need to look into more things. You need to do some research. If I have somebody in my life that is sharing biblical things with me, and it feels overwhelming, and it feels like it's confusing. Well, it'll say something here, and then it goes and turns around and says something here. And they seem like they're opposite, but they're not. So what do? I have to dig in deeper into the Bible and learn what is actually being said in this verse versus the other verse. So with you, as far as medical things are concerned, if one doctor is telling you one thing and another doctor is telling you another thing, don't you think it would be best to look into it before maybe just taking sides, whether it's my side or another doctor's side? I don't want you to take sides. I want you to use the information, and hopefully it spurs you into action. Look it up. I'm not here to spoon feed you. I'm not here to spoon feed you titles of studies so you can go click the link and read them, which you're not going to read them. You're actually going to read the abstract or the introduction. Are you going to read all of the results and then you're going to read the conclusion? It's doubtful. So you don't want to do any work, but yet you want to be spoon-fed the information. Okay? Well, I'm not going to do that much spoon feeding. I'm going to give you some information that might spur you to go look into things. If I tell you that cholesterol is a molecule, and that molecule has a chemical formula, and I can tell you the importance of having cholesterol, okay? I can tell you that 25%, that's a roundabout percentage of cholesterol is in your brain. Your brain is made up of 25% cholesterol. Your hormones, most of your hormones, are made from cholesterol. If you want to check your testosterone and your estrogen and your progesterone, your vitamin D, those are hormones that are made from cholesterol. Your cell membranes, they have cholesterol in them and fat. It's not the same thing. They have different chemical formulas. There's different types of fat. There's saturated, there's monounsaturated, there's polyunsaturated. We need to know the difference. Cholesterol, on your cholesterol panel, we might refer to it as a lipid panel, is not really a measurement because cholesterol can't be measured in the blood. You mean that's not real? No, I'm telling you that cholesterol cannot be measured in the blood. Why? Because the blood is water and cholesterol is not water soluble. So cholesterol is carried in lipoproteins. Lipo, fat, proteins. You might know them by other names called LDL, VLDL, HDL. Those are lipoproteins that carry fat and cholesterol. Cholesterol is not free in your bloodstream. It cannot be measured. Free cholesterol cannot be measured in your bloodstream. It is measured via LDLs, HDLs, VLDLs. And so if you know all of those values, you can make a calculation as to the cholesterol. With that being said, your lipid panel also calculates the LDL. That is calculated. If you look closely on your lab panel, it should say that it's a calculated, LDL. Now I'm really confusing you. So is it a true LDL? Well, again, it's calculated. You can get a direct LDL. You can get a direct LDL. Will that include some of the other components? No. LDL is simply a taxi. It is a vehicle that sends fat and cholesterol through the body. You cannot have LDLs for the most part. I'm going to give you one situation where this next statement coming out of my mouth does not abide by, okay? But generally speaking, you don't get LDLs unless you have VLDLs. Oh boy. Let me explain. VLDLs are made in the liver. VLDLs, like triglycerides, same thing, different name, same thing, fatty acids. VLDL are made in the liver when carbohydrates are consumed. When you eat carbohydrates, you increase VLDL. The liver is going to consume those excess sugars from the carbohydrates. It's going to use some. Your body's going to use some, right? You got a lot of muscle. Okay, you got a lot of muscle. Your muscle's going to take up some of that sugar, that carbohydrate. Your brain's going to take up a little bit. Some other glycogen stores, they're going to take it up. But for the most part, excess tells the liver to use it and make VLDL. And then VLDL is shuttled, VLDL is containing your fat and your cholesterol, and then it's shuttled out into the bloodstream. And a VLDL is pretty big. He's a big guy. And this VLDL, as he goes out into the bloodstream, and he's it's like a car in the train. He's carrying his cargo, and he's going to start dumping it off. And he's going to be smaller. So he's going to become an LDL. So a VLDL is going to dump off some of its stuff, and it's going to be an LDL. That is what we are having this grand, big, giant hubbub about, is LDL. Because there are schools of thought out there that will say that if your LDL is high, you are at risk of having coronary artery disease, a heart attack. Is that true? It used to be said that if you eat fat and cholesterol, you will have a heart attack. It raises LDL and you have a heart attack. Well, if you've read recent studies, and you're likely not going to be hearing this because they still want to fearmonger you. They still want to brainwash you to not eat fat, especially animal fats. Now, if you want to eat the same saturated fat and get it from an avocado or a coconut, it's fine. But if you eat the saturated fat from an animal, that's not so fine. I mean, think about that. The saturated fat from an avocado is okay, but the saturated fat from your ribeye steak is not. Is that because they're different? Do they look different? Does the LDL have a different chemical formula in an avocado than from your ribeye steak? I'm just curious about that. I'm just trying to get you to think through some things. So people will, the reason why this theory of eating fat that raises LDL is kind of going by the wayside, but you've not heard about it. And it's actually kind of laughable because they feared us into thinking that if we consume the fat, it'll go in our mouth, down our esophagus, into our stomach, and somehow go directly into the bloodstream. Maybe it didn't even reach the stomach. Maybe it just went from our mouth to the bloodstream. Either way, I'm not really sure how you get that, because how would you ever break down the fat, and how would you explain why we were made perfect as an image bearer with a liver, that one of its functions is to make bile? And then we were fantastically made to have a gallbladder that actually stores bile. I mean, do you think those are just incidental findings in our perfected body? I don't think so. So when we eat fat, it has to be broken down. Okay? And it's broken down by bile, by the bile salts that were made in the liver and stored in the gallbladder. When we eat fat, we need to break it down. And the bile breaks it down. And then that broken down, when the word broken down means, or the other name for it is called emulsified. Emulsification, breaking down of fat by bile. When that is happening, that broken down stuff needs to be carried in something. Because again, how does it ever get to what we think is the bloodstream? I know this might sound complicated, but we have a carrier, and it's called a chylomicron. And believe it or not, the chylomicron is actually bigger than a VLDL. So this chylomicron, he carries the fat and the cholesterol up the thoracic duct, and then it dumps into the vein. And then the vein to the heart, to the arteries. But they're transported in something, not just free flowing in our body, in our bloodstream. It can't. You can't. Okay? So if we have high carbohydrates, it tells the liver to use those, make fat, and store it as VLDL. And the VLDL is essentially dumping things off and making an LDL. And then it dumps stuff off, and then you have an HDL. And an HDL at the end brings it all back to the liver, and we start all over again. It's a process. It's more complicated than the simplistic things I'm telling you about right now, okay? But the LDL, my friends, is not the cause of coronary artery disease. If it were, we would have, it would be linear. It would look like this particular high LDL leads to a heart attack. But we know that's not the case, because some people have low LDL and still have a heart attack. Some people who have their LDL is high. Hear me out. Their LDL is high and they don't have a heart attack. So simply lowering LDL is not really all of the story. If we've learned something, we will know that LDL has some sort of a function in our body. It's a carrier. It's a caboose or a car on the train. It's needed for some reason. If you look deeply into that, you'll find out that LDLs are necessary for brain function, for immunity. There's lots of things that LDL is known for as a benefit, but yet these things aren't brought up by your doctor. They're going to just say, LDL, bad, here's your medicine. The other thing that I want to just a caveat, and I mentioned at the very beginning that I said, for the most part, every LDL starts out as a VLDL. A VLDL is produced by a high carbohydrate or carbohydrate diet. Is there an instance when this likely is not true? There is. And so, being forthright, I want to tell you about that. There are certain people who are called, and this is new. This is a new, you might have already heard it and say, that's not new, Dr. Jensen, but for some of you listening, this is relatively new findings called a lean mass hyperresponder. You might have a person who's very lean, muscular, athletic. They eat fat and their LDLs go up. And so do they fit the normal scenario of eat carbohydrates, get high LDL? No. These people, these lean mass hyperresponders who eat carnivore, no carbs, get high LDL. They're called lean mass hyperresponders, and they kind of go against the natural scenario. So you can already see that, wow, this is getting complicated, and I guess it wasn't so cut and dry, was it? No. Now, do these lean mass hyperresponders have a problem with coronary artery disease and heart attacks? We'll find out. I mean, more and more carnivores are in the world right now, correct? So we're going to start watching them, and we're going to start seeing, are they dying of cardiovascular disease? It's going to be a great thing to watch over time. These lean mass hyperresponders, that their LDLs shoot up. They don't always have to be athletes. I just gave you that scenario. They could just be a lean, muscular person who's just an active walker or whatever. They don't have to be, the bodybuilder or the long distance runner. I'm not saying that. I'm just giving you a scenario of what this particular person might look like. They're lean, they're muscular, and they're hyperresponders. They're making LDL. I could go into a really complicated process of why that is. I don't know if it's necessary, but let's just suffice it to say that on LDLs, the liver needs the protein that's on LDL, the ApoB. On the ApoB, the liver needs that protein for certain things that the liver does to make, say, a VLDL. So if there's no carbohydrates coming in, there's no VLDLs to be produced. So the liver doesn't really need the lipoprotein from the LDL. So the LDLs go up in these people. I know it sounds confusing, and maybe you don't need to know that information, but I kind of wanted to give you just a little scenario of how that's possible, a possible scenario of why lean mass hyperresponders exist. Are they at risk of coronary artery disease? So far, no. People who have high VLDLs from eating carbohydrates end up with a lot of small, dense LDLs. Small, dense, way down the line, small, dense LDLs. What is wrong with small, dense LDLs? They've lost all of their kind of protective mechanisms, so to speak. An LDL in and of itself is not as dangerous as if it got way downstream, lost a bunch of its cargo, and can get oxidized. Small, dense LDLs risk getting oxidized and making free radicals, reactive oxygen species, inflammation. These small, dense LDLs get picked up by macrophages. And these macrophages form into foam cells. These can be found in the plaque of people who have high plaque. along with red blood cells and white blood cells and platelets. All of these things can be found in plaque formation in an artery of the heart or in your legs. Arteries. Okay. So, doctor, tell me about, I get this question a lot, but I have a family history of high cholesterol and coronary artery disease. Everybody who's had high cholesterol ends up with a heart attack. Okay, but I need more information. Did your family members have diabetes? Well, no. Or were they checked? I mean, like, do we really know the other situations that were going on? All we hear is high cholesterol, heart attack. And we're not opening up or removing our blinders and looking at other causes that could be going on. And so when a person writes to me, and I get this all the time, but I have familial hypercholesterolemia. Well, from a doctor's perspective, that's actually a genetic disease. Familial high cholesterolemia, which really is not the right word for it, because I already told you that you really can't measure cholesterol, right? I told you that. It's calculated. But if somebody tells me that they have familial hypercholesterolemia, I ask them, were you genetically tested? Oh no, my doctor just told me that because my dad had it, my grandma had it, my brother has it, everybody has it in my family. That's not really a diagnosis of familial hypercholesterolemia. Now let's just say you are the person, your doctor did genetically test you, and you do have familial hypercholesterolemia. You got the gene. Is the gene telling you that LDL is the cause of their heart attack? No. Why does a person with familial hypercholesterolemia end up with a heart attack? And not all of them do. Imagine that. Only some of them do. Some of them actually, because they have familial hypercholesterolemia, live longer than a person who doesn't have familial hypercholesterolemia. You mean, Dr. Jensen, you're telling me that there's people who have very, very high cholesterol, it's familial, and they end up living longer? Yes, that's what I'm telling you. So what is it about some of the people having familial hypercholesterolemia? It's due to a part of that gene that increases their risk of having a blood clot. So you're telling me that it's not the cholesterol itself, it's actually the clot formation problem that they might have? That's exactly what I'm saying. That's exactly what I'm saying. So then death is not due to LDL. Correct. Now, again, this is my opinion from my studying. You're going to go to another doctor, perhaps, and they're going to have the opposite. But do they know every mechanism? Are they walking through it? Right now, with the amount of information I have gleaned from my research, I'm coming to these conclusions that it is not LDL. Because if it was, the lower we lower the LDL, like say 20, people still had a heart attack. And people who have an LDL of 300 for their whole life never have a heart attack. So is it the LDL? I'm saying no. I'm saying I believe that it's from blood clots, inflammation. Yeah, but what about when we do a test and they see plaque in my heart, they tell me it's from LDL. Well, they're telling you that because that's what they've been told. But what about all the other components? I'm not telling you that there's not a component of LDL in your plaquing. I think it's mainly small, dense LDLs, because how would a humongous particle like an LDL get across the arterial wall? I can't fathom it, because these endothelial cells in your artery are so tight that they really can't go between, the LDLs can't go between the cells, and they really can't go through the cells because the membrane of the endothelial cells doesn't really let anything go through, because then we would just be full of bacteria in our cells and we would be dead by now, or viruses, or whatever it is. That's how small the cell membrane is. Let's just say porousness. It's not very porous. It only allows certain things into the cell, like maybe the size of potassium. Now compare the size of potassium, intracellular potassium, with an LDL particle. So how does this plaque start on the other side of the lining? Because it's got to start back here. So if this is the lining, the inner aspect of the artery, how does the plaque start back here? That would mean that the LDL would either have to go through the endothelial cell or between them. I don't think either one of those can happen because the LDL is so big. Now, you could say, but what about the small dense LDL, Dr. Jensen? Still, the size is pretty big compared to what the porousness is of the endothelial cells. And do you recall that the innermost lining of the artery is not yet the endothelial cells? It's actually something else called the glycocalyx. So if you have a lining of the artery and you're taking it and you're doing an anatomy, your glycocalyx could be this thick, 2 inches thick. I'm making this up. I'm trying to give you something to put in your brain. Let's say it's this thick. And that is a protection. It's gel-like. It allows things to slide through, okay? It allows for protection, another protective barrier. But what if the glycocalyx is being destroyed? What if something is injuring the glycocalyx? Then the glycocalyx is going to become thinner and thinner and thinner. Now there may not be a glycocalyx. Now it's easier to damage the endothelial cells. But if it's just a one-time deal, you could damage the endothelial cell, and then a new baby progenitor endothelial cell will be formed from the bone marrow, from stem cells, and then it'll replace the injured guy. We have that normal mechanism in our body. But what if that injury is constant? What if it's something you're doing on a regular basis that's damaging the glycocalyx? It can't reform. It's now starting to damage the endothelial cells, and the bone marrow can't keep up with little baby cells to replace it, to replace the injured ones. What if this is a possibility, a scenario that's going on? And then now you can get an injury, a scab formation. And that scab is going to attract all of the things that make a scab, which is like a blood clot, right? If we don't get a scab on our skin, we're going to bleed to death. If it doesn't stop, we're going to bleed to death. But we have mechanisms in our body that bleed and then stop and bleed and stop. And those are repair mechanisms, and they're supposed to be in sync with each other. So if we don't want to bleed to death, so we have an inability to make a clot. And then we don't want the clot to just stay there forever, like the scab, it falls off, but we don't really want it to fall off inside of our arteries. We want it to dissolve. And so we have a mechanism in our body called fibrinolysis. That's one of the mechanisms. It could be 50 different mechanisms, but that's just one. And that helps to break down the clot so it doesn't just stay there and calcify. Now, some doctors would argue, well, a calcified clot is better than a loosey-goosey one that breaks off and goes to your brain. I would agree. But why are we having the plaque build up in the first place? Okay? We need to figure out what is causing the injury to the lining of the arterial wall, starting with the glycocalyx. And I just wrote down a few things, okay? I wrote down sugar. Do you think sugar is supposed to be freely swimming in our bloodstream? No. That's why we have a mechanism, we have a pancreas that secretes insulin to help lower blood sugar, however that might be. Put it in the muscle cells, put it in the fat cells, put it in the liver, wherever it's got to go to not be in the bloodstream. Because in the bloodstream, it's like pouring acid down your pipe at home. Not a good thing. It destroys it. Think about the people who have blindness from diabetes. It's destroying the micro vessels, the capillaries and the arterioles in your eyes. What about your kidneys? What about your toes? And we start getting amputations. You see, sugar is toxic. On the flip side, insulin is also toxic in high amounts. When we need insulin, but we don't need it in the amounts that we have. And so insulin can even be toxic to the arteries. What else? Heavy metals, cadmium, arsenic, mercury. Those are toxins to our arterioles. What about smoking? And by the way, does heavy metals have anything to do with LDLs? If LDLs are the cause of your coronary artery disease, your heart attack, then how would that explain how people with heavy metal exposure, diesel fumes or pollution, how do you explain them having a heart attack? I know, right? That has nothing to do with LDL. Their LDL might be where they need to be at 100. What about smoking? Smoking anything, even if it's a wood burning fire, that's smoke. You see, it doesn't just go in our mouth or in our nose, it goes into our lung. And then because the lung has areas where you have porousness, that smoke particle goes through the lung, the alveoli, and go into the bloodstream. That's how it gets there. That's how smoking anything, smoking any plant, any smoke from a plant, including wood, including, your tobacco, your marijuana, whatever it is, it will get into the bloodstream. That is a toxin to the arterial walls. And none of that has to do with LDLs, does it? Does any of that does smoking raise LDL? No. So where does this LDL thing come from? Eventually, this LDL scenario, this story, is going to go by the wayside. You know that that's happening because at first they said it was cholesterol, high cholesterol, heart disease. Then it's really not cholesterol, it's LDL. Now it's not going to be LDL, it's going to be small dense LDL, or it's going to be LPA. Oh my gosh, what's LPA? Well, you might know it as LP little a. LP little a is also a molecule in our LDL particles, but it not only has an ApoB, it also has an ApoA, and they will tell you that it's hereditary and you can't be lowering it unless, of course, there just happens to be a pharmaceutical company that can make a medication that will lower LP little a. Remember, folks, if you look for it, i.e., you let your doctor do diagnostic testing on you, diagnostic testing leads to diagnoses. So if you check for it and it is there, you now become a patient and you now become treatable. Are you going to treat your LP little a with the LP little a medication that they told you can't really lower LP little a because it's genetic? I've actually seen LP little a go down in people who are on a carnivore diet. Imagine that. Okay. So the next question that I get a lot of is, Dr. Jensen, I was put on a statin, and this all came round robin with I am collaborating on some storylines with Divine Carnivore. And I'm collaborating because I wanted to tell not only my story, but my dad's story. And that causes, when you start talking about statins could be a problem in people and we shouldn't be on them, you're going to get a lot of people who have experiences with high LDL and heart attacks. It's hard to undo the experiences and the brainwashing that some of us had. They're not going to look at heavy metals. They're not going to look at nanoplastics, which I forgot to mention. They're not going to look at alcohol, which I also forgot to mention. They're not going to look at smoking. They're not going to look at insulin or blood sugars or sugars in the blood. They're not going to look at heavy metals. They're not going to look at niacin. They're not going to look at iron. They're not going to look at sickle cell disease because they got their blinders on and they only see LDL. So you can imagine if I start collaborating on a story telling people about my dad who had a diagnosis of high cholesterol. And so they told him that he should take a statin. And so he took a statin. He still got 5-vessel coronary artery disease. So it didn't stop that. He took the statin for many years, I would say 20, 25 years, and he still had coronary artery disease, 5 vessels. My dad also obtained a type of Parkinson's disease. We'll get into what the negative drawbacks of a statin are, but suffice it to say, if I alluded to the fact that that statin could have worsened my dad's illnesses. In addition, when the doctor told him to take the statin, they also told him to lower his fat and lower his red meat. If a person lowers their fat, they go fat-free, and they lower their amount of meat, you are going to have to eat something. And that looks like an increase of carbohydrates. So my dad went from eating whole foods, basically, lean meats, or we ate everything. We had hamburger and pork and we did have chicken, but he strictly went low fat everything to the point he was boiling his chicken. He stopped all red meats. He ate fish. He did eat fish, but not very often, only when we went out. He didn't want to make it. So he replaced all of those, I don't want to say calories, he replaced the food he took out, the macronutrient he took out, he replaced it with carbohydrates. Carbohydrates increase VLDL, carbohydrates increase LDL, increases our risk of having diabetes. Did I ever check my dad for diabetes? No. I was hyper-focused on LDL because that's what I was brainwashed into thinking. Instead, my dad, what I think, pushed his coronary artery disease into oblivion by eating all of the carbohydrates, increasing the amount of VLDL, producing the amount of LDLs. Statins are not the holy miracle grail. Trust me on this, I'll get to it. But by lowering the fat in my dad's diet and taking the statin to lower his cholesterol, what do you think happened to his brain? Could that be the reason why he got a type of Parkinson's? Could it be the reason why he was getting some neurological problems? He was getting dizzy and memory problems and falling. Then he broke his femur, got put into a nursing skilled care. Do I know? Am I just speculating? Absolutely. I'm just giving you scenarios to get your brain to start thinking, okay? We're put on these statins. Do you know from studies I know you want to hear the studies, Dr. Jensen. Show me the studies that higher LDL actually increases longevity. I told you about the hypercholesterolemia people, right? Some of them lived longer. Well, how can that be? They didn't have a heart attack because of blood clots. Because some of the familial hypercholesterolemic people had blood clots. My dad never had a heart attack. He was just found to have coronary artery disease. When you look at the cholesterol, then you start looking for other things called diagnostics. And now we got a diagnosis of coronary artery disease. No chest pain, no nothing. And you know what they did with that? Oh, he's got blocked arteries. We're going to go fix them. There goes your CABG surgery, coronary artery bypass graft. We didn't leave anything alone. The doctor actually mentioned, he said, Mr. Jensen, you are a very lucky man. Because you were a runner and an exerciser and you didn't smoke, you had collateral blood flow. And the collaterals fed your heart. You mean, doctor, they're still feeding the heart? Yes, Mr. Jensen. Then why do I need the coronary artery bypass graft? Well, we should just do it to protect you. Oh, you mean kind of like the statins? Yes. I don't have any symptoms. I don't have any problems, but you're going to protect me. Yes, that's exactly what we're going to do, Mr. Jensen. And because my dad, Mr. Jensen, was awesome at following directions and really trusted his doctor, he said, okay, I'm going to take the statin. Okay, I'm going to eat no fat. And I'm going to stop all red meat. And years later, you get repercussions. Oh, that could happen to anybody. Oh, sure it can. You're right. It can. We're just speculating. We're just guessing. But do you know how many people were telling me that they had the same experience? Maybe with their parents, maybe with themselves? I mean, do you just say that's coincidental? So if it's not LDL, Dr. Jensen, why are we doing the statin? That's a great question. Studies show that higher LDL leads to longer life, especially in elderly people, in advanced aging, in mature adults. Then what is the statin doing if there's any benefit at all? Well, let's talk about it. I'll get that question. I have to be honest with people. Is there a benefit to statins? Yes. Yes, there is. Statins help stimulate the endothelial cells in the artery lining to make nitric oxide. Nitric oxide is an awesome molecule in our body that helps to vasodilate and acts like an anticoagulant, anti-blood clot. So, doctor, if you know that the statin decreases a risk of blood clotting, why are we messing around with LDL? Oh. See, now you might be getting your doctor to start thinking a little bit, like using their brain, instead of just being spoon-fed what is fed to them in medical school and residency and continuing education. All of it. It's all sponsored by the exact same people. They did the curriculum. They taught every doctor. I actually paid to have that curriculum spoon-fed into my brain. And I let it spoon-feed me for 20 years. I've been practicing for 27. 20 years I was spoon-fed certain things, and I paid for that. I had a debt of about $200,000 when I got done with all of my training. That includes everything. I'm not just saying medical school. That could be medical school right now, $200,000, but not from when I went, okay, 27 years ago. So the benefit of statins, nitric oxide production, anticoagulation, decrease the risk of a blood clot. It's anti-inflammatory. anti-inflammatory. You might ask yourself, okay, so if statins decrease, let me get that off of here. If statins decrease my risk of having a blood clot and they decrease inflammation, is there anything else I could do besides taking a statin? Because we know that there are side effects of a statin. I'll get into that in a minute. What is just as good as taking a statin that will maybe raise nitric oxide, that'll help vasodilate, that'll decrease my risk of having a blood clot, that is anti-inflammatory? Well, I would tell you that that could be a low carbohydrate diet, a low or no carbohydrate diet, the exact opposite of what you're being told by mainstream. You see, mainstream will tell you that you should eat 5 or 6 servings of grains, and you should eat 4 or 5 servings of fruit, and you should get minimal, if any, meats, because those are, oh boy, they raise LDL, and LDL causes a heart attack. No, they don't. They're just a carrier of things in the blood. Okay? Now, you're probably wondering, Dr. Jensen, I think I'll just take the statin because I want to be safe. Okay. Do you have enough information? Yes, I do, doctor. Thank you very much. I'm good with it then. But I need to really explain to people what a statin or what any drug does in our body. Most, if not all drugs we put in our body block a normal biologic process in our body. Simple as that. Okay? Now, if I block a normal biologic process with a statin, what is that doing? If you look up HMG-CoA, you will see a pathway that leads to cholesterol. It also leads to CoQ10. It also leads to vitamin K. It leads downstream to other things besides cholesterol. So you will give a statin, which is called an HMG-CoA reductase inhibitor. So you're inhibiting the reductase. That is simple word for an enzyme. So you're going to inhibit an enzyme that helps HMG-CoA break down into these other things. So you're not going to get the things downstream. There are studies out there that show that you won't get 50% of the CoQ10 that is produced in this pathway. The pathway is called the mevalonate pathway. Why the heck do we need CoQ10? Good question. We need CoQ10. One of the things that CoQ10 does is it is used by the mitochondria. Those are inside cells. Mitochondria are we call them the powerhouse of the cells, the energy producers. Well, the mitochondria need CoQ10 to make ATP. The mitochondria need CoQ10 to make ATP, your currency of energy in your body. So if we're down 50% of our CoQ10, what does that look like for the mitochondria? Struggling. Your mitochondria are struggling without the building blocks it needs to make energy. Oh, but Dr. Jensen, I was told to take CoQ10 with my statin. Did that even raise a red flag to you? Because what we said to patients, hey, this statin, it depletes CoQ10, so you better take some. We were actually forthright in saying that. So we're going to block a normal biologic process that makes CoQ10 that your mitochondria. I bet the doctor didn't even know that. It's lip service. It's words that they read. Oh, you know what? Your statin will deplete CoQ10. If they even remembered to tell you this, they don't even know what CoQ10 is. They don't know why you need CoQ10, but they told you to take a synthetic version of it. We're going to block way downstream some cholesterol. And in the process, we're going to deplete all these other things. So I need you to go and just take some synthetic, man-made things that you may or may not be able to use. That CoQ10? Right. And it's not really just the CoQ10, because CoQ10 is not the actual thing that's being used by the mitochondria. It's a breakdown product. Again, there's processes that's going on, millions and millions of process. We just think the CoQ10 actually goes right to the mitochondria and is being used. No, he's got to break it down into something to be used. It's not just the whole CoQ10 molecule. I'm just trying to be simplistic for you. But there's some in-betweeners before the mitochondria can use it to make ATP. So what if you can't even break down that big capsule of yours? Could that be why my cells and my muscles and everything feels like weak? Is that why I'm getting muscle aches and pains? Is that why my brain functions not so well? Is that why I'm getting brain fog? Is that why I was tested positive for dementia, Parkinson's, MS, ALS, all of the neurodegenerative diseases that are going on? What about my depression? Everything has a consequence. Do you know what the doctors will tell you? Yeah, but the benefits outweigh the risks. Well, to them it does. To them, the LDL's the problem. They're not going to keep seeing you. You know, once you have your first heart attack, you're not going to go back to your PCP. You're going to just stick with your cardiologist. They're kind of out of the picture. They didn't know that they actually caused the problem. They're not going to take responsibility for your diabetes. Well, the statin didn't really cause your diabetes. It just made it harder for you to metabolize your glucose. But you're not going to be with them. They're going to say, oh, you know what? You here, just take the medicine. Just take the medicine. You got diabetes, just take the medicine. And then that medicine caused something else, like kidney failure or something like that. But don't worry about it. Those are just normal progressions as we get older. I mean, things are just going to wear out. I mean, it's almost like putting your foot on the brake and the gas pedal at the same time. It's just what happens when you get older. I mean, you've lived a good life. These things are just going to happen. And, you know, it's just a normal process of aging. This is what you're being told. And then the doctors are being protected because they're spewing the stuff that they've been fed. They were spoon-fed and they're just spoon-fed. And as long as they stick to the scenario, nothing can happen to them. But if some doctor speaks out, that doctor is a quack. They're dangerous. They should go to jail. This is what's happening over and over and over. It's not just with LDLs and statins and heart attacks. Your doctor's not telling you about what you're doing that's causing these problems. So, yeah, the statins can cause muscle aches and pains and maybe a little brain fog. And yeah, there's an increased risk of diabetes, but we're lowering your risk of cardiovascular disease. But you being a smart person said, but doctor, isn't diabetes the number one cause of coronary artery disease? Yeah, but we're going to lower your LDL, which has really been shown to cause the heart attack. Where is that data? I'll wait. You guys, the statin is not something that's pinpoint, that's going to just work in this one area. Once it gets in your body, it works all over your body. That's why we have many, many side effects, many adverse effects. If you look at a recent study and you ask, some of you, my listeners are really smart, and they're going to ask this question. Doctor, you told me about the risks and you told me about the benefits, and in your eyes, the benefits outweigh the risks. Okay, I'm on board with what you're saying. Okay, I'm listening. Now, doctor, tell me, if I take this statin for 5 years, I've never had any cardiovascular event. I'm like me. I'm an athlete. I go to sleep and I get up and I do the things and nothing's wrong with me. I've never had a heart attack. I don't have high blood pressure even. What benefit does it give me if I take this medicine for 5 years? If I'm on it for 5 years, what is the benefit? 5 extra days of life. What if I've had an event? 4 extra days of life. So you're telling me that if I take it for 10 years, and in my case, I took it for nearly 25 years, I'm only going to get 15 extra days of life? And I could risk getting diabetes and dementia and depression and schizophrenia and MS and ALS and Parkinson's? That's a hard nut to crack right there. I don't know if I'm on board with that. Well, then suit yourself. Okay, I guess that's it, right? Are we done? I mean, that's all there is. What about the blood clot thing, doc? What about the inflammation thing? Well, that's what the statins are for. But isn't there anything else? One other thing. Let me just say why the increased risks of dementia. And I want to tell you, this is awesome. Why is it that statins increase our risk of these things that occur in our brain? All of the conditions, the symptoms that occur in our brain. It's just that some of the statins are called lipid soluble. And then there's some that are water soluble. And so the lipid soluble statins can cross the blood-brain barrier. That's why there's increased risks of neurodegeneration in the brain with statins. So if you notice recently, and first, let's tell you what the lipid soluble statins are. Lipitor, which is atorvastatin, Zocor, which is simvastatin, and Lescol, or I think Mevacor, is lovastatin. They're fat soluble. And so as more information is getting out there, curious enough, some cardiologists are switching their Lipitor people to Crestor people. And you know what the reasons are? Well, the study results indicate that they're just better at lowering LDL and reducing the risk of cardiovascular disease. But what they really didn't tell you is that is a water-soluble cholesterol medicine, like Pravachol, Pravastatin. And so they're starting to switch their people. Maybe because they're seeing more dementia, some more Alzheimer's. Did they really tell you? Do they even know that the difference between lipid soluble and fat soluble, or lipid soluble and water soluble? I mean, you would think they're a cardiologist and they would know all of these things, right? Or wrong? So this is where it leaves us. with information in regards to statins. And if you guys have questions, I have skipped through a lot of questions because I wanted to paint a picture, okay? I want to paint a picture of what you're being told, and I want to add to it. I'm just adding to a story to help you make better decisions. Janet asks, and you guys, if I skipped your question, please restate it again, okay? Because it is very difficult for me to go back and look at all of your questions that may have arisen, because I am sure I am stirring your brain and your heart right now, and you're wondering, what the heck am I going to do now? Do I just stop the statin? Can you do that? Well, sure you can. The only person in my eyes that will suffer from not taking a statin is your doctor. You see, the way doctors are reimbursed these days is that the insurance companies want certain things to be done. And they will tell the doctor, these are the criteria. If you meet the criteria, you get paid, sometimes a bonus. So if you have high cholesterol and it's over their magical number, you get placed on a statin. If the doctor complies with prescribing you a statin and whatever else needs to be complied with, he will get or she will get their bonus, their insurance payment. Okay? Meanwhile, who's paying the insurance companies? Good question. Now, if the doctor writes the prescription and it sits at the pharmacy, the doctor still does not get reimbursement that they deserve or they're thinking they deserve. You decided not to pick it up. It never gets recorded, but you will get a letter, and so will your doctor. Patient seems to be non-compliant. They haven't picked up their scripts. You, the doctor, start shivering in your booties, your boots, because you are going to lose your incentives from your payments from the insurance companies. And so you don't like that. So you have your nurse make a call. You didn't go pick this up. Could you go please pick it up? Well, that will help the doctor. Does it help you? You don't want to necessarily get harassed by the nurses, by the doctors, by the insurance company. So you pay your copay, a couple bucks because they're generic, and you let it sit and build up in your home. You are avoiding any controversy, any feedback from anybody, insurance companies or otherwise. So you just pretend. Now everybody looks like everybody has got a win-win situation until you go back to the doctor and you have high cholesterol and they say, are you not taking your medicine? And you say, no, I'm taking it. Or you tell the truth and say, no, I'm not taking it. Well, we really need to increase your dose. New script. Some people will say, I'm just going to take it 3 days before my test and call it good. Is that possible, Dr. Jensen? Yeah. If you take it 3, 4, 5 days before you get your fasting blood work, your LDL will be low. And remember, an HMG-CoA reductase inhibitor stops the production right there on the spot. Once you block that HMG-CoA reductase enzyme by the inhibitor, the statin, there's no more cholesterol being produced. You know, I read on one of the feedbacks is, well, you can just take it every other day, or you can take it twice a week. How dumb is that? I'm going to block the enzyme, and then I'm not going to block the enzyme, and then I'm going to block it, and I'm not going to block it, and you're going to do that for the rest of your life? I don't think that's a good scenario. High cholesterol, low cholesterol, high cholesterol, low. Do you think that your body's going to have a little bit of rebellion? What kind of a recommendation is that? I'm going to take it once a week. So it lasts in your system 3 days. So you're gonna be blocking cholesterol production for 3 days, and then for 4 more you're not. Oh no, maybe I'm gonna split it up. I'm sorry, I can't get on board with that one either. Can coronary ultrasounds give a general idea of what's going on the rest of the body? Or do we really need to get a CT scan with calcium score to be sure? Well, explain to me what your coronary ultrasound is. Are we putting dye in you? Are we doing just an echo, which is, an echo will just show you, is that what you mean? I'm guessing that's what you mean by your ultrasound of the heart, coronary heart ultrasound, and we call it an echocardiogram. Is that going to tell you what's going on in your arteries? No. It's going to tell you what's the function of your heart is doing. That it will do. It'll give an ejection fraction. It'll give valvular structure, but it's not going to tell about the arteries. Okay. Do you need a CT calcium score? I guess that's up to you. I mean, some doctors will say no. Some doctors will say yes. What do we use it for? If you do a diagnostic test, you're going to get a diagnosis. If you have a diagnosis, you're going to, honestly, you're going to be a patient. A diagnosis causes a patient to be formed, and then a treatment plan. Yeah, but doctor, I just want to know. Then you just want to know, get it. What are you going to do about it? What if I say, oh my gosh, your score is 100. I think you should take a statin. You said no. Then why did you get it in the first place? Well, I just wanted to know. Well, you just cost yourself some money. I don't care. You become a patient now. Yeah, that's okay too. Then good. You had enough information. I'm good with it. You had enough information to make a decision. That's fine. But if you're saying, I want to get a baseline, and then I want to recheck it in 2 years and see if it's progressing, okay, I can get on board with that too. Well, can calcium scores go down? Maybe I want to check and see if it's gone down. Well, I think they can, but some doctors say it's impossible. But I've seen it. In fact, I just saw it 3 days ago. I saw a calcium score from 2 years ago. It was like 278 or something like that. Please do not quote me. And then they just got a calcium score and it was 230 something. So it went down 30, 40 points. Well, that's not really a lot, Dr. Jensen. It's still elevated. I know, but it didn't progress. It actually regressed. This person is not on a statin. In fact, they kind of backed off on their exercise program. They kind of mostly, I hate that word, eat carnivore. So they eat carnivorous most of the time in their life. Do they still eat some odds and ends of carbohydrates? Yes. And the calcium score went down. The only new thing that they did, besides they just couldn't find time to exercise, is they started taking something called glucoferrin. Look it up. Ask people on here how many people are taking glucoferrin. I've seen plaque regression in my patients with glucoferrin. This particular person has only been on glucoferrin 8 months and saw a 40% reduction. Or it's not 40%, I'm sorry, 40 point. And just to be perfectly clear, that does not equal the amount of plaque in your body. That does not equal. It's, if you have calcification, you have a problem going on in your coronary arteries. If the score is 0, you have less of stuff going on in your body. Less inflammation, less risk for blood clots, those sort of things. There's just less risk of calcium being built up in your coronary arteries. It does not equal the amount of narrowing. Do not hear me say that the higher your score equals closing up of the arteries. That does not equal that. It's just a screening tool that says, hey, you got a calcium score here of above 0, and there's a problem. And I think you should try to do something about it. Well, this gentleman took glucopharen and eats a majority of his life carnivorous. Okay, sounds like a great action plan. So what are you going to do with the results? Okay, just know that before you jump into all of these tests. Hopefully, Janet, that answered your question. Ruth from Iowa says glucopharen. Yes, at glucopharen. Janet says, sorry, not a coronary ultrasound, a carotid ultrasound. So what was the question? Shoot. Janet, what was your original question? I've lost it. Okay. Here's your carotids. Here is your coronary. If you're getting a CT scan, a calcium scoring test, that is for your coronary arteries. An ultrasound of your heart, will not show calcification, yes, an ultrasound will not show the coronary arteries and any calcification going on. It shows function of the heart. Will a carotid ultrasound show calcification? No, but a carotid artery ultrasound will show narrowing. Could you assume that there is plaque formation? Yes. That's how we usually find carotid artery disease. We will do a carotid artery duplex. Carotid artery duplex. Okay? So a CT score, a CAC, a calcium scoring test, however you want to do it, say it, will not tell you anything but calcifications score above 0. If you have calcification in your heart arteries, the possibility of you having in your carotid arteries is also pretty high. Okay? Hopefully that adds to your answering your question. Yes, Ruth says water-soluble statins are excreted more quickly than lipid-soluble. That says a lot. It does say a lot. But that doesn't answer it for everybody because not everybody has a fat on their body. Some people are lean and they still have high cholesterol and they're going to be put on a cholesterol medicine. But yeah, it is possible that if you are obese, that you could have that statin sticking around in your fat longer. It's possible. It's fat soluble. Ruth also says lipid soluble statins penetrate the penetrate the brain and cause confusion and memory loss, and they also cause muscle symptoms. Yes, I agree. Jayco says carotid artery ultrasounds show what? Narrowing. They show narrowing, you guys. So if I am doing an exam on you and I listen to your heart, I next go to your neck and I will listen on your carotid arteries. I'll listen on your neck and I'm listening for bruits. I'm listening for swooshing sounds. I'm listening for that. If I hear that, my next thing is to get a carotid artery duplex because it's non-invasive, it's easy to do, And it might indicate whether or not that person has narrowing of blood flow to their brain, to their head, upwards from the heart. If there is narrowing, we suppose that to be from calcification or plaque formation. And I've actually been in on carotid artery surgery. It's been a lot of years, but it is pretty gnarly. I don't even use that word, but it is whoa. So the doctor makes a cut, so to speak. And this is in the olden days. This has been years. I'm saying 25 years ago, this is what they were doing. So they would, make this cut. And then it was almost like they could pull out this hollow snake from your carotid artery. Some parts thick. It looked like, honestly, it was odd. It was the oddest thing. I just couldn't believe it. I remember going home and I was telling my dad, and I go, you won't believe what I saw today. I mean, they pulled out this plaque out of this artery. Like they rotor-rooted it. It was crazy. I will never forget that. Dr. Thompson. I will never forget my time with Dr. Thompson. Wow. Let's see. So hopefully I answered the questions about the carotid arteries, the calcium scores. Okay, Jaco says thank you. So that apparently answered that question. Here's oh, this is interesting. Lori says LP little a. They, the experts, say you can't reduce the number with lifestyle. Lori fasted, ate low carb for 1 year. Her LP little a went from 150.3 down to 56. Is my result an outlier, Lori? No, not according to me. I check LP little a's because my patients are educated. They know about LP little a. And so they will ask me, check my LP little a. I know that small little particle could be a risk factor for coronary artery disease, a heart attack. It can be a risk factor for a heart attack. Among other things, I know that, Dr. Jensen, but check my LP little a. Hers went from 150, which is very high. I mean, they say over 75, you need a statin. Statins don't lower LP little a. Statins don't necessarily, well, they will tell you that they don't lower anything but LDL, or there are some people that have lowered their triglycerides. But remember, when we take a statin and it lowers LDL of all sizes, it doesn't pick and choose. A statin isn't going to say, ooh, I'm just going to lower small, dense LDLs. No, it's going to lower the large LDLs as well. So when we're taking a statin, we have to realize all of these things, not just one-sided stories. So for Lori, she saw her LP little a go down on a low-carb diet. I've seen it go down as well on a low-carb carnivorous diet, no-carb diet. It's going down. They told you it can't be done because it's genetics, yet they can have a medicine that will just so happens to bring it down. Okay. Ruth says, N of 1, be smart, get smart, follow Dr. Jensen. Yeah. And Lara says, that's awesome, Lori. Great job on lowering your LP little a. So what is a good LP little a? I say less than 10. We need a little bit because in all honesty, what is wrong with LP little a? Well, what if I told you that he could possibly increase the risk of blood clots?